Okay, so good afternoon, everyone. This is like after learning some quantum physics, we are back to some very basic rules of mathematics. So after watching this complex case, I will try to finish this indications and assessment of peripheral vascular disease and indications of peripheral intervention pretty quickly. It's a vast topic as such, but pretty basic. What we are going to do is look at the peripheral vascular disease, which is like any other atherosclerotic vascular disease, can occur anywhere in the body, and there are some very important areas where the peripheral vascular disease can end up with significant morbid consequences. Large proportion of patients with significant peripheral vascular disease are asymptomatic. So the challenge is detecting this set of patients who can benefit with intervention. Even though they are asymptomatic, they may have increased risk of cerebrovascular and cardiovascular events, and these patients can be detected, many of them, especially in the lower extremity, by an ankylobrachial pressure index of less than 0.9. Screening is effective, as shown by many epidemiological studies, in identifying patients with asymptomatic as well as symptomatic undiagnosed peripheral vascular disease. They have 30% risk when they are symptomatic of death within 5 years, as shown by many epidemiological studies, nearly 50% within 10 years. Many patients with peripheral vascular disease assume that their symptoms are part of growing old, so do not present to their physician. It can be easily detected in clinical practice, doesn't need much of equipment, just awareness about the presence of peripheral vascular disease needs to be there, and it needs to be increased amongst the patients as well. Peripheral vascular disease should be considered in any patient with exertional leg pain, patients more than 50 years old with diabetes, patients more than 50 years old who are currently smoking, all patients more than 70 years old, and recently ACCHA has added a corollary to it. This criteria has been downscaled to 65 years old. Anyone more than 65 years old does merit a quick screening for peripheral vascular disease. It may also be present in patients with evidence of past TIAs or strokes, suspected carotid artery disease, non-controlled or uncontrolled hypertension, abnormal renal function tests, where there may be a renal artery disease, or in cases of diagnosed coronary artery disease, the peripheral vascular disease may be present as well. The techniques used to diagnose peripheral vascular disease should include review of medical history, which is very important, physical examination, very quick, very important, and then diagnostic tests, which are pretty non-invasive and should be considered in all at risk or in all the patients who are symptomatic. Lower limb peripheral vascular disease, intermittent claudication is typically when presents as leg pain on exertion. It starts with walking uphill, reproduced by the same degree of exertion. It is relieved by rest. Lesions are usually found in arterial segment one level above the affected muscle group. Calf claudication or hip, thigh, and buttock claudication are pretty common. The rest pain is more sinister, typically interferes with sleep, may occur during the day when the patient is resting in supine position. That time also, pain is localized in the distal part of the foot or calf, and partial relief may be obtained sometimes by a short walk or mainly by the dependent position, and often the patient sleep with their ischemic leg hanging over the edge of the bed or sitting in an armchair all night. Peripheral pulses are the most important thing to be examined, auscultation for bruise and limb examination as such. Palpation by far seems the most accurate and telling method of diagnosing peripheral vascular disease. Judging by degree of palpation, you can even surmise to some extent what kind of severity is there. Clinical examination of the lower limbs is very important when you are contemplating peripheral vascular disease treatment. Hair loss on lower limbs and poor nail growth, dry scaly atrophic skin, dependent rubor, pallor with leg elevation and ulceration, etc. may tell us what degree of peripheral vascular disease is there. Diagnostic tests for PVD, ankle-brachial index is one where I would, which one I would harp upon. It confirms the diagnosis of PVD many times. It gives you very early detection. It provides a semi-quantitative assessment of severity of PVD, progression of PVD over time, as well as response to intervention for PVD also can be judged with ABI. Can be performed very easily in office with standard blood pressure cuffs and Doppler, relatively quick. ABI index of 1 to 1.4 is normal, and less than 0.9 is strongly associated with limitations in lower limb functioning. Between 0.9 to 1 ABI is considered borderline. The steps are pretty simple. Upper extremity, once cuff is deflated, first Doppler sound recorded at the radial pulse, then cuff is applied to the calf, recorded at DP. There are machines which do all this very quickly and give you a very nice graph as well. To summarize the ABI, patient has to be resting supine for 5 to 10 minutes, and you take systolic pressures, and whichever is higher is the denominator value. Similarly, in the leg, whichever higher is the numerator, and then you take the clinical algorithm would be something like this: history and physical examination or symptoms.